Good afternoon. Thank you for joining us for the latest event in Community Grand Rounds, Healing the Trauma of Racism. My name is Lynn Todman. I am the Vice President for Health Equity at Spectrum Health, and I'm delighted to have you join us this afternoon to hear from a wonderful speaker, Dr. Nwamaka Eneanya, who is an attending nephrologist and assistant professor of medicine and epidemiology at the University of Pennsylvania. She's also the director of health equity, anti-racism, and community engagement in the nephrology division. Dr. Eneanya holds an undergraduate degree from Cornell University, a medical degree from Meharry Medical College, and a master's degree in public health from the Harvard T.H. Chan School of Public Health. She completed her residency in internal medicine at Brigham and Women's Hospital and her nephrology training at the Combined Nephrology Fellowship Program at Massachusetts General Hospital, Brigham and Women's Hospital. Dr. Eneanya is a clinical investigator with research interests that center on palliative care, informed decision-making, health equity among patients with chronic kidney disease. Her research has been supported by the National Institutes of Health and the American Society of Nephrology. In 2020, she was recognized as a 40 under 40 leader in minority health by the National Minority Quality Forum. Dr. Eneanya, we're delighted to have you.
Thank you so much, Dr. Todd. I'm hearing an echo. Now I don't. Thank you so much for that wonderful introduction. And I think you need to stop sharing. Perfect. Now I can share. I'm honored to be here to talk about a topic that's so timely and something that I'm so passionate about. And that is the care for Black patients with kidney disease for numerous reasons. As Dr. Todman has already stated, I am a Black nephrologist. I went to an HBCU for medical school. So this kind of care and this type of work is ingrained in me. So I just want to make that clear. So today we'll talk about racial justice and kidney disease and what we have learned. So objectives will first to review some economic and social disparities for Black individuals in the United States. And I think that's really important to highlight. Because when we talk about racial inequities, sometimes people confuse racial disparities in Black patients for it having to do with something being wrong with Black people. And that's absolutely not true. And we'll go over that. And then I'll kind of highlight some of the disparities in clinical care that we know actually exist broadly for patients with kidney disease, and really focusing on kidney disease in this talk. And then lastly, we'll review some strategies for how to confront and decrease racial disparities in clinical care. And the message is really geared towards clinicians and healthcare systems, but I think it's important to hear kind of what is being told to doctors, right? When they learn about health disparities, because not everybody has this knowledge about race disparities and what that means. And every time I give a talk to med students or doctors, this is what I focus on. And so let's talk about a case that I saw, a clinical, a patient that I treated in the hospital. And this is patient NB. I'm going to use her initials to keep this anonymous. But she was a 24-year-old female who had sickle cell disease and kidney failure that was treated with dialysis. And she was coming to the hospital with pain crises, very common for someone that has sickle cell. We decided that when we examined her and spoke to her, that she really needed to be admitted for a blood transfusion, pain control, and dialysis treatments. So a little bit more about patient MB is that she was having a difficult time with healthcare. She did not have a primary care clinician. So you can imagine having sickle cell disease and not having a primary care doctor is really kind of a detriment, or it hurts the patient when you don't have someone that can kind of link you to all of these different doctors. She did have hematologists, so she did have somebody who was treating her sickle cell, but she was kind of jumping around in different cities in Pennsylvania. She didn't have a home. So she was homeless. She was living with different family members, halfway homes, kind of living on people's couches which made it really difficult for her to get dialysis. For you to get dialysis, you need to have what they call a stable home address, a physical home address that you live at. And that is how they reserve your seat in the dialysis clinic for you to get dialysis. So she was really getting dialysis very infrequently, which is very dangerous. And then she also had these kind of social stressors. She was a single mom. Their father was in prison. So she didn't have really any support. And so, you know, I took a look at her medical chart, as I normally do for patients who appeared like this patient, who don't have a lot of social support, maybe don't have a home. And I found that she had been in the hospital 18 times over a 1.5 year period, all for the same kind of reason. And that was sickle cell anemia. And so you can see here, some of her visits to the hospital were separated just by a few weeks, very close. So as I was looking at her chart, I was reading, you know, all of her notes, whether that be social work notes or notes from the nurse or the doctor, and certain words kept jumping out over and over again. I want to share some of those words. Poor insight, non-adherent or non-compliant is another way we think of that. Unlikely to be sickle cell pain, missed dialysis, poor compliance, over-medicated with pain meds. And then lastly, we kind of have this common words that we use when someone is discharged, and it's the patient was discharged to home in good condition, which we know was not the case for this patient, right? Look how many times she had been admitted over the 1.5 year period. And so just really wanted to share sometimes the things that can be in the medical chart when people like her who have a lot of social needs are coming to the hospital. So the question is, you know, what is the best treatment plan? How do we treat a patient like this? What is the best care for her? But then more importantly, and this is something to think about, you know, we don't ever think about what gets into our medical charts when we're getting care. But if somebody's reading the chart about you, does the doctor already feel like they kind of know you, right? About reading about you and not without even meeting you or talking to you, and kind of what kind of biases are formed before they even meet you? I think that's really important to keep in mind, kind of the biases that can creep into medical care when we're thinking about clinical management. So let's talk about structural racism. Okay, structural racism is important. I realize that this topic has been included in previous talks, but structural racism is defined as a system in which public policies, institutional practices, and cultural representations and other norms work to perpetuate racial group inequity. So these are privileges associated with whiteness, right? Just how somebody looks. So white is defined as your facial features and your hair color and your skin color, and that's really where it ends. And then there's disadvantages associated with color, whether you're Black or you're Hispanic or Asian or Native American. And so structural racism is a system that is just based on how you look and who gets what resources. So what does that mean for economic and social differences that we see across different races in the United States? So this first graph here on the left is from the US Census Bureau. And what it shows is household income differences by race and ethnicity. So you can see here on the bottom is time to 2018. And then over here is the income up to 90,000. And we can see as of 2018, this is across again, the United States, for an Asian household, their median household income is 87,000 versus 70,000 for white individuals, and 51,000 for Hispanic individuals versus 41,000 for Black individuals. And so you can see here that these trends over time from 1959 to 2018 are very separate, right? Really never crossing, never intersecting. Now, we look over here at the same kind of graph. This is from the Pew Research Center, and this is looking at median net worth by race and ethnicity. And so net worth is defined by how it's basically all of your assets, whether that be bank accounts, property, all of that minus all of your debts, okay? And we can see here on this graph, as of 2013, for a white household, their median net worth is $142,000 versus $11,000 for Black individuals and $14,000 for Hispanic individuals. So these are some very, very large discrepancies, again, the impact of structural racism is causing these differences between the different race and ethnic groups. And then here we look at educational disparities and what does that look like? So this again is from Pew Research Center. And this is a graph that shows the number of US adults who are age 25 or older who have at least a bachelor's degree in college. And we see here as of 2015 that 53% of Asians have attained a college degree versus 36% of whites versus 23% of Blacks versus 15% of Hispanics. So again, very large differences. So what am I trying to get at here when I show you these differences in economics and in social factors? And that is the social determinants of health. So the World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. And we know that things like income, education, racial neighborhood segregation, food insecurity, not being able to afford or having that worry of not being able to afford nutritious foods that are appropriate for your health, crime, all of these things have been intimately linked to your health. They've been linked to mortality, whether you live or whether you die early compared to the rest of the US population. And so these are where we see differences between race and ethnic groups in health outcomes. And so when people talk about racial disparities, I want to make it clear that it's not about something's wrong with me, I've done something wrong, I've caused this, I've brought this on myself. That is not the case. It is a structural systemic issue of racism that has caused these differences, which disproportionately affects Black and brown people. And so let's focus a little bit more on neighborhood segregation and what does that look like? Because neighborhood segregation has really been the focus now of a lot of healthcare research, and a lot of healthcare systems are very interested in this. And so let's use Boston as an example. So I lived in Boston for 10 years. I know like that city like the back of my hand. It's very segregated. And so this is an example of the city, or this is a map of the city, and you can see these areas very clearly delineate where people of different racial groups live. So in the red, we have a lot of Asians in the South End, that's SE. And then in the orange, Dorchester, Mattapan, Roxbury, that's where we see the majority of Black residents. And then Latino residents are kind of concentrated in different areas of the city. And then you see white residents are concentrated in different areas in different neighborhoods. So keep this picture in mind, because we're going to go over some of these trends that I just talked about with social determinants of health. Now let's look at the number of individuals who have not graduated high school. Can you actually see in this graph the areas where I was saying were Black and Hispanic individuals? This is mostly Black here. This has a very high number of individuals that have not graduated high school, concentrated right in this area. And then this is showing unemployment rates. So you can see here again where the highest rates of employment are in the Black neighborhoods, in the Hispanic neighborhoods. Here we see household income, and where household income is low in the city or high. So high is this darker purple, and low is this lighter shaded purple. Again, right? We're seeing this track very closely in the neighborhoods where Black and Hispanic individuals live. And the white neighborhoods are, you can see a high income or household income in those areas. Let's look at the poverty levels. So light means that the poverty level, like the people living under the poverty level, living below the poverty line, are these light areas. And then the darker areas are people, a high proportion of people living below the poverty line. And you can see here where that's concentrated in the city. So what does this mean? So there were a group of researchers that wanted to look at life expectancy in Boston based on your neighborhoods. And they did this kind of complicated analysis to look at what that actually meant. And what they found was that between Back Bay, so Back Bay being the most wealthy part of the city, and Roxbury being a neighborhood that has, again, majority Black individuals, that there was a life expectancy difference of 33 years. So you can see on this map, this is actually 3.8 miles, right? Some of us who are more fit can run, I can't run that, but some of us who are more fit can just jog that, right? In less than an hour, 30 minutes and reach this area. And there's a 33-year life expectancy. So if you're living here, you can expect to live, or you can expect to die 33 years before someone on average who's living in Back Bay. So that just show you the power of neighborhood segregation and the power of structural racism and concentrating that oppression in areas where majority Black and brown people live. So let's shift gears to disparities in clinical care and kind of review what that looks like for in the United States. So this publication called Unequal Treatment was published by the Institute of Medicine. Now they're actually called the National Academy of Medicine in 2002. And it was it brought together all of the brilliant minds of people who have studied racial disparities, health disparities in the United States. And they wrote this publication, which is actually free online. If you try to order the paper copy, you have to pay, but you can access it online. And they talk about disparities in kidney disease, heart disease, cancer, organ transplant, HIV/AIDS, asthma, maternal mortality, pain treatment, and palliative end-of-life care. All of these things, we know that there's rampant racial disparities in all of these categories that still exist. So this is, almost 20 years ago, we know that these disparities still exist. So what does that look like for Black patients with kidney disease? Well, this this is from our national data, which shows people who have kidney failure that need treatment with dialysis or transplant. That's the most severe stage of kidney failure. And you can see over time, this is 2000 and 2016, this curve shows exactly who's being affected by that, Black and African American, right? And down here, you see Asian, you see American Indian in this yellow curve, Asian in the orange, and then white down here at the bottom. And so again, over time, very, very large effects on people's kidney health. What about kidney transplantation? This was a very interesting study that made national news that looked at who is receiving a kidney transplantation. So I just showed you that Black individuals are more likely to have kidney failure compared to other racial groups. However, if you look at this trend here in this blue line, Black people here are the ones that are least likely to receive kidney transplants, least likely to be sent for kidney transplant evaluation, least likely to be evaluated or to actually complete the evaluation process, least likely to receive a transplant from their family members. So we can already see again the effects of racism here when we're thinking about outcomes and actual treatments for patients with kidney disease. Transplantation is actually the only way to cure kidney disease. Dialysis is not the cure. It's transplant. So this is what I aim as a kidney doctor to have all of my patients do who are physically able to do this, is kidney transplant, yet Black and brown people are affected by this. We see Hispanics in the orange and Asians in brown, and then whites in this kind of green curve. What about palliative care? So palliative care is a lot of my research has focused on palliative care, and that's defined as care to really improve quality of life for patients who have any type of disease. You don't have to be in the ICU. You don't have to be dying. You just really have to have a chronic disease that's affecting your livelihood, and palliative care aims to improve your livelihood, whether that be symptom management, social support, whatever you need to help improve your disease experience. And we know that there's racial disparities in palliative care. So individuals who are a minority racial or from minority racial and ethnic groups experience barriers to palliative care. There's less advanced care planning. And this is defined as having discussions with your clinicians, your doctors, or your family members about, hey, what kind of care would I want if I do end up in the ICU and it's not looking good? Do I want CPR? Do I want a mechanical ventilator? We don't have these conversations in our community. We have them significantly less than members of the white community. And it can be really detrimental, not only for you, but for your family members. Again, we have less discussions about the care that we want. So this involves documenting what you would want. This is discussing with your doctors and your family members or friends who you kind of designate to make your healthcare decisions, we don't have those discussions. And I've had research that shows that for Black families in particular, there's more of a preference to focus on extending your life at the end of life. There's research that shows that for Black individuals in particular, they are more often likely to die in the ICU more often than other racial groups. And not to say that if you want that, that's fine. But if you poll the general American public, most people don't want to die in an ICU. It's scary, it's loud, you're being poked, it can be painful. And so why does that keep happening to Black individuals? And there's also less hospice use in the Black community. And we'll talk a little bit more about what my research has shown with that. Now, the question here, the million-dollar question is, why do we see these disparities in something like palliative care? And some research has shown it could be for Black and brown people, language or cultural differences. It could be religion differences. Are your doctors having some type of bias when they're talking to you about that? Is there a way that there's a breakdown in communication? Is there health literacy? And that means not being able to truly receive medical information to help you make your medical decisions. There's poor knowledge of palliative care resources such as hospice. And then there's also this mistrust of the healthcare system. We're seeing that play out live now in the COVID-19 pandemic, whether that be with getting vaccinated or wearing masks, or just knowing when, if you have COVID, when to go to the hospital and get care. A lot of that is wrapped into this and why we see disparities for Black and brown communities. So this is some work where I looked at end-of-life care for patients on dialysis. And what we did was look at who received like really intensive care at the end of life, who was on a mechanical ventilator in the last 6 months, who was maybe getting some feeding tubes, getting kind of poked and prodded to get their food, who was getting CPR. And you can see, we looked over time, and then we divided, or we separated those trends by race and ethnicity. And we can see that Hispanic individuals, no matter the age, these different colors and dots show you like different age groups, but overall Hispanic individuals and non-Hispanic Black individuals had significantly more intense care in the last days of their life compared to white people. And if you kind of just put these graphs very close to each other, you would see that these trends are parallel. So what is happening over a 12-year period that Black and Hispanic people are dying in the ICU as opposed to white people? Why is that? You know, these are the questions that we need to focus on. And so this was a study that looked at hospice knowledge for patients with kidney disease and how, and if they understood what that meant. And so we basically asked this one question, and that question was, have you heard of the word hospice? And if you have, what does that word mean to you? And so when we actually kind of polled everybody's response and said, you know, do people have good knowledge or do they have poor or partial knowledge? 17% of Black patients had good knowledge of what hospice was versus 61% of white patients. That's a very big difference, right? Almost 3 times the difference. And so let's look at like an example of a poor knowledge response. So poor knowledge is for hospice. Well, let's start with good knowledge, actually. So good knowledge, somebody said this in quotes, it means that it's giving care to someone in the end stages of life. It's compassionate care among family that helps someone ease into death without pain. It could be at home if desired. But this is a Webster definition. I mean, somebody said this, right? I didn't give them this definition. It's like a dictionary definition of hospice. Now, a poor knowledge response is, it's a place where people who can't take care of their activities of daily living are taken care of. Or over here, it's where people go to be taken care of after an operation. Now, if we just think about what that looks like, right? If you have this good knowledge of hospice in your head, what does that mean if you're very sick or you're actually becoming very sick and someone brings up the word hospice? Are you going to readily accept that based on the knowledge that you have? If you think it's where people go to have an operation and no one really actually sits down and explains that to you and your family members, I mean, for me, I would say I don't need an operation, right? What does that have to do with me? I don't want that. And so, really focusing on, how we educate and communicate about some of these powerful resources that are not only good for you, but the support that it gives your family is super important, and really starts to kind of try to tackle why we have some of these racial disparities at the end of life. So what about this pain and these differences in pain? This was a study that made major headlines because it was published in 2016, so 5 years ago, and it was done among medical students, right? So the next generation of medical students, this study was performed. And what they did was to ask medical students, white medical students at the University of Virginia, are there differences? Are there biological differences between Black and white patients? And what does that mean? And so when they asked questions like that to the white students, many of them, actually 50% of them, had one false belief about biological differences. So an example of a false biological difference that they thought was that Black people had thicker skin compared to white people. Or they were asked, do Black people have less sensitive nerve endings just, because they're Black? And people believe that. And then they were asked to read, a kind of a mock case about a Black person coming in with pain and a white person coming in with pain, and to make recommendations about their pain and how to treat that pain. And this graph shows here that those who believed about false biological differences between Black and white people were more likely to rate a Black patient, that's in this bottom curve here, as having less pain, just because they're Black. So this is very important when we're talking about kind of the crux of how racial discrimination and structural racism has affected healthcare and health disparities for our for Black individuals in particular. We know that there's research studies that show that Black people are routinely undertreated for their pain. They're not believed. And you can imagine why, if this is being taught early on in the process, how that can make a doctor think that they're doing the right thing if they think that Black people have thicker skin or less sensitive nerve endings. And so, the other thing that I've really been a part of are some of these tools that are being used every day that incorporate very clearly Black race. So as of now, there's several tools and approaches where they actually plug into that calculator Black race, Asian race, or Hispanic ethnicity. No other race, by the way. It's not white. We're not talking about nationality like, I'm from Germany. This is just race. And so there's tools that are used to kind of see how your kidney functions. There's tools to see how your lungs function. There's tools to predict your chances of having heart failure and death if you go to the hospital, or your risk of having a kidney stone or surviving rectal cancer. A lot of these calculators are actually available online, and they use Black race and other race. There's also a tool that's that looks at whether you're able to have whether you'll need a cesarean section after having a vaginal delivery. Vaginal deliveries are preferred because they're safer. And all of these tools essentially put Black people in a different category. So for instance, for this tool right here, Black race, when you put it into the calculator, or Hispanic ethnicity says, yeah, you're gonna need another cesarean section. We're not gonna try a vaginal delivery with you. You're just gonna get the cesarean section because you're Black. And so it's been really powerful to be a part of a movement where we're getting rid of the Black race piece in these tools. So I can say confidently, as of today, because we just got a hot off the press update, 2 of these tools, this tool, they changed this tool a few months ago, and just today, 2 hours ago, the National Kidney Societies removed Black race from tools that are used to determine whether you have kidney disease or how your kidneys are functioning. So it's like a win, okay? We have a few more to go, but the movement is moving towards, let's take this bias out of these calculators that are really dictating what kind of care you should have. It's not right. It doesn't make any sense. We are not different biologically. And so, I'll end on this piece, or I'll kind of wrap up this disparity piece with implicit bias. And implicit bias is something that we all have. It's the unconscious bias that we have towards people of different race, gender, religion. We have that because of our life experiences. And this was an episode, it was an NPR podcast that I would encourage everyone to look. It was so beautifully done. And what they did was look at implicit bias and how that affects communities of color when it comes to police brutality. And so what they found was that if they went to a certain neighborhood that was having a lot of police brutality against communities that were Black, if they actually measured implicit bias, because there's tests for you to measure if you have an unconscious stereotype or unconscious bias towards a Black person, if they took one police officer and measured their implicit bias, that actually did not predict whether that neighborhood was having a lot of police brutality. What predicted that is if you actually took the bias and measured that among all of the community members, not just police officers, everybody. And if there was a lot of implicit bias towards Black people in those communities, then that is what predicted the police brutality. And so I use this as an example to say that if we're going to change our practices in clinical medicine and really start to shift our thinking about bias and Black people being different and, you know, Hispanic people being different biologically, it's going to take the entire community, the entire scientific community, the entire medical community to kind of move the needle. Just you looking up your bias yourself and trying to change your practice is not enough. So lastly, I'll end on some ways that we can confront and decrease disparities. So I'll show this as a way to kind of, you know, bridge this from the last example that I used, and that's checking your bias at the door. And I encourage, you know, clinicians and health systems to do this implicit bias testing. This is the website where anyone can go, implicit.harvard.edu, and you can take your test and see, do I have a bias against Black people? Wait, I'm Black. You know, or do I have a bias against white people or, you know, people who practice Muslim religion? And you can just be aware. Now, again, that awareness is great. It's not enough to move the needle, but I think as this infiltrates into the community and to healthcare systems, it could be really powerful, a powerful tool. If you recognize your bias, and if everybody's recognizing their biases, they won't be so defensive if somebody calls them out. And that is what the implicit bias literature has shown, mostly from corporate kind of hiring practices, is that if you're in a group and you're doing something and someone says, nah, I don't think that Black person I don't think we should hire them. And someone kind of calls you out on it, like, why did you say that? Their resume looks amazing. That is enough to move the needle. And so I would encourage everyone to do this, but this is something that I push doctors to do as well, is to check your bias at the door. Let's stop putting words in the medical chart. If you read those words, take them with a grain of salt, get to know the patient yourself. And that leads me to my next strategy. And that is really improving the doctor-patient relationship. We can only really improve healthcare inequities, racial disparities, if we are trusting our doctors and having our doctors trust us. And so if there's cultural differences, linguistic differences, that can help. I'm proficient in Spanish, but you best believe I try my hardest with the interpreter, of course, there to fill the gaps, to really connect with my Spanish-speaking populations. It goes so far. And I would encourage, if anyone speaks a different language that is outside of what your doctor is speaking, to make sure that they bring the interpreter in. And that's how you start to build that relationship. Start talking about food, start talking about what kind of holidays you celebrate. I tend to try to ask these things in addition to the medical care that I'm delivering. So I make sure that I'm building that trust, and it's not all about numbers and test. The next thing is, I need to phone a friend, and I have that here. When it comes to caring for certain patients, I went to medical school. I didn't go to social work school. I'm not a case manager. And so when it comes to treating patients like the patients that I kind of described in the beginning with high social needs, I need help. And so having teams and having healthcare systems really embrace having a team of doctors, nurses, social workers, case managers, Whoever needs to be on that team to effectively give the best care is what I vote for. That's what I advocate for. And that is really the way forward, right? Because I told you about the social determinants of health. I don't know how to address many of those things, but I know that it's affecting health in particular for Black and brown people in the United States. So we need teams to deliver that care. We need patient education. I showed you a kind of a salient example of hospice and hospice knowledge. A lot of my work has focused on dialysis knowledge. A lot of people, don't have a choice or have minimal choices about the dialysis treatment that they receive. They just kind of sign up for it because maybe their friend had it or they heard something about it without really knowing that there's like 3 types of dialysis. And one of those dialysis may work better for your lifestyle than the dialysis where you go to the center. And so having education programs that are more geared towards educating patients early on in the disease process is really a good way to, again, move past these inequities that we see in our clinical outcomes. And then lastly, we as a healthcare community need to do a better job of recruiting more racial and ethnic minorities into the healthcare force. We can't do this work, just with a few of us sprinkled here and there. And I know it's always my goal when I'm hiring or recruiting to make sure that it's inclusive and that people of all types of backgrounds, whether that be race and ethnicity, whether that be whether you're disabled or or you bring that perspective to the team, that is all needed. And I can't stress that enough, is that we need diversity in our health professions. And so I'll end there. In summary, that there are social and economic disparities in the United States that disproportionately affect minority, racial, and ethnic groups. Social determinants of health and bias greatly contribute to care received by Black individuals in the United States. And there are numerous strategies that we can all implement to improve care and simultaneously reduce racial disparities. So I end there and ask if there's any questions. I think I ended on time.
Yes. Thank you, Dr. Eneanya. You did.
Sure.
Thank you very much.
Absolutely.
There are a couple questions that I'll read for you. One person makes a statement and then a question. It sounds like health literacy is important for helping people understand things like palliative care or hospice. What are some of the ways you've seen healthcare systems proactively work to educate patients and the population around these issues in a culturally responsive way?
This is a great question. There's actually, there's been a lot of work done by the Institute of Medicine or the National Academies of Medicine to make sure that healthcare organizations are deemed as health literate organizations. And that is very simple. So when I was in grad school, I took a health literacy course, and we were tasked as students to go to a different hospital that we'd never been to before and kind of find the cafeteria, find the radiology suite. And when I tell you that was so hard. I mean, the signs were, all confusing, like things were not clear. And so really changing signs. And I'm not just talking about the language. I'm talking about what did the arrows look like, like what does the figure look like? There's actually a list of things that healthcare systems can do to make sure that people from all walks of life can navigate and actually get to your appointment. And so that is one of the ways that you can, that the healthcare system can be proactive and be culturally sensitive. I know a lot of healthcare systems also have just clear statements. We are an inclusive organization. We are an inclusive hospital, have different signs in different languages according to the patient population that they treat, have different flags from different countries. I think all of those things contribute to responding in a culturally responsive way.
What about specifically communicating around palliative care and hospice? Because we have the same issue in our community, the underutilization of those services by African Americans and Hispanic people.
Yeah, so I think this one is a little bit trickier because I lost you somewhere. This is a little bit trickier because palliative end-of-life care is so highly stigmatized in the United States. So if you go to a different country, there's nowhere near the type of intensive care that we do in the United States. And so I think this is, you need kind of a multidisciplinary approach The best that I've seen is, for instance, in the Black community, we know that this is not done. The palliative care is not received as often in the Black community. I've seen large Black churches do education to their church members about this, right? Because it could be very easy to say, put it in God's hands, right? And, I'm Christian, I go to church, and I absolutely believe you should put it in God's hands. But we also should be educated about what those resources are. And I think it's well received with community partners like churches or other faith organizations where there may be some kind of, the way that you're interpreting it is that it should be healthcare or God, and it really should be both, right? And I think that is an effective way. That's one of the best ways that I see. There was a church in Boston that did that, in getting that information out to the community.
Okay. Another question that's come up, and one of the reasons that I particularly was attracted to your work was this notion of race modifiers. You talked at the CME about that, and maybe you can tell folks a little bit about what they are. You alluded to it in your presentation, and how they actually can contribute to disparities in kidney care. And I wonder if that actually contributes to the low rate of transplants for Black people.
Yeah, no. So yes, I try to, nephrology can be so high tech. So I kind of skipped over it, but as simple as I can say is that some research showed in the past that there needs to be a different kidney function for Black people versus every other racial group. And so the race modifier, what it does, would assign Black people as having better kidney function just off of the strength of you being Black. And so if you have better kidney function, that means that you're going to be less likely to be sent to someone like me, a kidney specialist, who'll be very focused on making sure that your kidneys remain healthy for as long as possible. Also, if Black people are assigned better kidney function, you're less likely to be listed for a kidney transplant or to be sent for evaluation. And so this has been the way that race modifier has been harmful for a population of people that we know, I showed you the curves, are more likely to have kidney failure compared to every other group. How is that fair, right? They're kind of discrepant. They don't make sense. We know this group is more likely to have kidney disease and kidney failure, but then you have these modifiers that are saying that you're healthier? Why? So I'm so proud of that red X that I put on the slide. I was so happy when I could put that on there officially, because I've had to keep everything kind of mum, but that is gone. And so if you see that in your healthcare system, make sure that you ask the doctor, I thought there was a new equation or that doesn't have Black race in it. Can you tell me more about that? And that is a way to advocate for yourself.
We have a lot of questions here, so I'm just going to go through them. So someone asked, how are these racial biases addressed, if at all, in medical school to ensure that doctors graduate with a culturally sensitive and responsive approach to medical care?
How is it taught in medical school, you're saying?
Yeah, that was the question. I think you gave a great example of what you were asked to do to go and navigate your way around a healthcare system. But is there any other part of the curriculum that teaches graduate students how to be more culturally sensitive and responsive in their care?
Yeah, so I think, all medical curriculums teach doctors, some better than others, to speak in layman's terms. I think that is probably one of the biggest things that's pushed to make sure that everybody receives information equally. That's one way. The curriculums that are coming out more recently, I would say in the last 2 to 3 years, are really starting to speak very frankly about racism. Now, going to an HBCU for medical school, that was used all the time, right? Nobody was scared to say racism this is racism that. I think in majority schools, which is the majority of medical schools, that hasn't always been the case. And now there being curriculums that are teaching. I mean, I just finished helping some Penn doctors do their curriculum to teach about kidney disease. And I'm like, racism needs to be all over this presentation, right? It has nothing to do with Black people being different. This is racism. And I think that is the first step going forward, because if you think about it, a lot of people, that's not their reality. Racism is just not, right? Is they don't have to confront it. But that's a lived experience for many of us that are Black or brown. And so this is starting to infiltrate into the curriculums. What is racism? How is that specifically affecting care? And what can we do to overcome or to change the effects of structural racism and discrimination?
Thank you. And I have a question about the role of insurance companies in making some of your recommendations a reality, but also, is there some kind of role the insurance companies will have in ensuring that the recommendations from these professional associations are adhered to, for instance?
Yeah, so I know for this, brand new, hot off the presses, new equation that does not use Black race for kidney function, that is a task from the National Kidney Foundation. That is what they do. They're more of an advocacy organization, and they've been working with insurance companies, policymakers, to make sure that this happens. I mean, it's all over the internet right now. And so they are the ones that are really going to say, hey, you have to change this. You have to change this. This is the newest update, and this is what we have to do.
Yeah. And another question is, how can we utilize the information that Black people are more likely to suffer from kidney failure to improve care for the youth in Black communities?
I think there's a power of the anecdote. And as you can see, I like to use clinical cases to get my point across. I think for that specifically, what you just raised, I've been keeping a mental list, for instance, of Black hip hop artists that have died from kidney failure.
Really?
Being Black Rob, right? Freeway, he's a rapper from Philly, was on dialysis and just received a kidney transplant like a year or two ago. So these are extremely wealthy hip hop artists that have diabetes and hypertension, the number 1 and 2 causes of kidney disease, and did not get that information that, if they didn't control or, really seek to get care for those 2 diseases, that their kidneys were going to fail. And so I think that, having, relatable examples can really be powerful for Black youth about how, hey, look, wealth and fame will do nothing for you if your diabetes and your high blood pressure are not controlled. We have wealthy members of the hip hop community who have died from this. I think Phife Dawg was another one from Tribe Called Quest. I have a list because
Are they young? They're young people?
And they are young. They're not, I don't know if the youth is like teenage, but I know that teenagers do listen to that music. And so I use those as kind of examples. The rappers were like young enough, like 50, late 40s, and they're dying.
Yeah.
So I use that to kind of help the youth understand that you got to get control of these things. It's not just about grandma or mom and dad having it. This can affect you too, and to kind of get ahead of that.
Yeah. Someone says a high achiever Black friend of mine said he would never sign an organ donor card because he believed that hospitals would not treat him as well, in the hopes that he would decline and take his organs. Is this a widespread perception?
It is. And unfortunately, it's not true. I am a proud donor. And let's just say that it would be illegal and to not do standard of care. So if somebody is to not be treated, who's coming in with some life-threatening illness and they're not treated, something is happening to that doctor and to that hospital if they don't perform standard of care and make sure that that care is delivered to that patient, regardless of their race. I understand that there's a fear, and we're trying to do this in Philly. Actually, a lot of the urban radio stations are doing kind of donor drives and making sure to say that, Black individuals are disproportionately on the transplant list, right? We need more people to donate their organs. Not to say that you have to be, that you're going to get somebody who's Black, but the more organs we have, the better. And again, our community that's being kind of left behind. And so I try to push for that for anyone that asks my opinion.
Okay. Another question is there a template or any guidance that an African-American counsel in a hospital system can present to an administration to remove the racial modifiers from labs?
Yes, if you just Google, you can find it on the internet today. I mean, I can type it in the chat, but if you Google 2021 CKD epi equation, you will find it widely on the internet. And you can show the internet that the major kidney societies have recommended immediate implementation of this new equation that does not have the race modifier. You can actually find the calculator online right now through the National Kidney Foundation. You can plug in your own numbers and see what your kidney function is without race. So it's available.
Yeah, I know this is outside of your professional expertise, but I just know, maybe it's not, this whole idea of race modifiers doesn't just happen in nephrology. You alluded to that the changes with respect to OB. Are there any other kind of pending changes? And maybe you can explain to the audience how detrimental these race modifiers can be and how they do play a pretty significant role in creating these health inequities and disparities.
Yeah, I mean, a lot of them were developed with the false belief, again, that there's biological differences between racial groups. And just to say, in 2003, there was a large genetic, it's called the Human Genome Study. They looked at all of the genes, basically all the genes that they possibly could find, and found that there was no collection of genes that were specific to a race. And they also found that people look more alike genetically in between racial groups as opposed to looking alike genetically within a racial group. And so a lot of these tools were developed prior to that.
I get it.
And so again, I was taught in medical school, Black people have more muscle mass than white people. And this is why we have to do the race modifier for kidney function, because muscle mass can affect how your kidney function is viewed. And so I think there's a racial reckoning that has been catalyzed with the murder of George Floyd, that racism is here. There's no, it's here. It has not gotten better. It's alive in medical practice. And so and Congress has gotten involved, by the way. So the Ways and Means Committee, which is the part of Congress that writes legislation, wrote a letter to all of the societies that use race in their calculators and said, you need to answer why you're using this and what you're going to do about it. And so that happened last summer. And so every different society, whether that be OB-GYN or cardiology, are all in the process of doing what, nephrology did, reviewing the literature. How do we get here? Is it harmful? And if it is, get rid of it or replace it. And that is ongoing. And I know there's a ton of interest. I mean, people even outside, I've been approached by the pulmonary doctors because of the lung function tests that use Black and Asian race to help them get rid of it. And I'm like, gladly, I want to help get rid of all of them, So it's ongoing, and there's brilliant minds that are being put to the test, and they're rapidly trying to change things. There was another calculator, a pediatric calculator that uses Black race to predict who gets a urinary tract infection. They took that out of their calculator last month. So it's happening.
Wow, that's amazing.
Yes.
I think we have time for one more question. Well, there's two quick questions here. So one is a quick one. Is medical apartheid getting widely read at your institution?
It's not, but I recommend that book to everybody. It is amazing. I think it should be required reading for every medical school curriculum. And it is becoming more popular. I have to check to see if that's on Penn's list. They use one of Dorothy Roberts' books, Dorothy Robert being a sociologist that's looked at a lot of these issues. But it is a fantastic book, and I highly recommend it.
She was our speaker last year, Harriet Washington. Yes, very good company. And the last question we have for you is, do you believe that the pace of change will be highly correlated with the increase of diverse physicians in the healthcare field. Given the single-digit representation of Black and Latino physicians, how much time do you think we are looking at before we see measurable change?
Well, I can tell you right now that the HBCUs, the four that are here, Howard, Morehouse, Meharry, and Charles Drew, still produce the largest proportion of Black physicians in this country. And so there's been a call to fund them heavily because every year they struggle because of racism. They struggle heavily with funding. And so there's been a large push for many powerful people that we need to robustly fund the HBCUs. I mean, that's just that. I think that, people are opening medical schools and we need to increase the number. We also need to be more inclusive of doctors who are immigrants who don't train here. Right now, it's terribly restrictive for no reason, right? I think, again, diversity on all fronts, race, ethnicity, everything, sexual orientation, religion, all of that is needed. And so we just need to stop being restrictive in the United States and being so narrow about who and who cannot practice medicine in this country. But I'm hopeful that things will change, but it's been a long time coming that these numbers have remained this since the 60s. We know that the proportion of Black men in medical school is less than what it was in the 60s. So major change is needed and it needs to be sustained.
Okay. Well, I said we have 2 more minutes and another question came through about race modifiers. The rise of race modifiers seemed in some way tied to a fundamental misunderstanding of interpreting data, that is correlation not equal to causation. Would you agree? And if so, do you feel that healthcare is becoming overly dependent on metrics without asking deeper questions about root causes?
These are fantastic questions, by the way. These are great. I do. I actually, so, that's part of when I give these talks, I show this in the CME talk, like the deep dive into the statistics of like, what are we seeing? And I think this is becoming more common in now graduate level programs on how to use, first of all, how to design a research study where you're not going to just group Black people in a different category than every other racial group when you have multiple. That doesn't make sense. Right there, you're setting yourself up for example. You're othering Black people. That's one. So I think the data is starting to be looked at in a different way, and people are starting to bring in some of these social factors using validated tools to make sure that they assess these social factors that, again, we know for a fact are causing the racial inequality. So one that has become very popular is called the Area Deprivation Index, and it looks at neighborhood deprivation. It looks at your mortgage or your housing value. It looks at the disparity in income in a neighborhood. It looks at how many people is there more than one person per room in each household, and that score is highly predictive of racial disparities. And so I think as people move forward with this kind of AI, artificial intelligence, and predicting who's going to get readmitted and who's not, and who's going to have heart failure, they're more incorporating that. That is more salient, is having deprivation scores of neighborhood or social deprivation, as opposed to just race, which we can't measure, which is a political social construct. And I heard this nicely put the other day. Race just shows where you are in the racial caste system. That's it. Like, that's pretty much it. That's as superficial as it gets. So I think those tools are much more substantial in really getting at the crux of the issue.
Well, Dr. Eneanya, our hour has come to a close. I don't know if you want to make one final comment or observation, leave us with anything.
Thank you so much for attending and all of this like critical and passionate engagement. I would say that my message is to continue to advocate for yourself. I told Dr. Todman earlier, I was lucky to be on the Doctors TV show talking about medical racism, and I've gotten people self-referring themselves. Keep pushing for that. It's unfortunate that we have to do that in this day and age, but advocate for yourself, advocate for your family members, be informed. And that is really the way forward as we continue to learn as a healthcare system how to better deliver clinical care. The advocacy and trust building is key as well. So thank you.
Thank you. Thank you, Dr. Eneanya. And thank you, those of you who have joined us this afternoon. I think we have one of my colleagues would like to share with you some information. We have found that many people, when they attend community grand rounds, have lots of questions and want to have discussions after these sessions. And so we have organized Brave Talks as settings for those kinds of conversations. And I think Mary is Mary going to do a presentation or what?
Not a presentation, but thank you, Lynn, for introducing Brave Talks. Just very quickly, what is Brave Talks? It's a free of cost, informal, facilitated gathering of 8 to 10 community members. So, you can invite your friends into this very safe space and dive into 6 sessions where you understand how structural racism impacts health. Our hope is that you will learn how systems like the healthcare system or housing or education limit access to important resources and opportunities for people in communities of color. These discussions aim at shining light on the ways in which institutional policies and practices impact all of us and contribute to negative health outcomes for many of us. So we are confident that you will be energized and feel empowered to be a part of this change that you want to see, because you're here at this webinar, attending, listening, and I am hopeful that you want to continue your educational journey. So if you would like more information or think are ready to join a Brave Talks group, the contact information is on your screen. And we thank you very much for joining us. And we hope that you've become even more curious to explore the structural nature of racism and how it's embedded in our systems. So thank you.
Thank you, Mary. Well, I believe that brings our session today to a close. There is you will get a survey. We hope that you fill out the survey. So we use this information to improve on our programming. The next presenter coming in about a month or so, Daniel Dawes, who wrote a book called Political Determinants of Health, which will also be an exciting and interesting presentation. We'll be here at the end of November, and we'll be providing details of that on the CGR website, on Spectrum Health Lakeland's website. So I believe that's it. Thank you for coming, and we look forward to seeing you the next time we host a Community Grand Rounds event. Thank you.